So welcome back. We're starting the second session now, which is on long COVID research. I'll be chairing the first part of this session, but then Marianne and Professor Danny Altman from the previous session will be chairing the Q&A at the end of this session. So we're looking forward to a really exciting session discussing the latest in long COVID research. And it gives me great pleasure to welcome our first speaker, who is Professor Stefano Aliberti from the University of Milan. And he's from the End COVID Clinical Research Collaboration, which is a project I'm sure he will tell you about, but is an ERS project looking into the problem of long COVID. Stefano, welcome. It's a pleasure to have you with us.
So thank you so much, Professor Chalmers. It's really a pleasure to be part of this kind of meeting organized by the ELF, ERS, and Dragon, and I'm really enthusiastic to share our perspective. My job would be to discuss a little bit about the latest research, but I don't want to bother our audience. So I decided to organize my presentation in three different sessions. The first one would be to give you an idea about the kind of research methodology that had been applied for long COVID evidence. And then I will touch a little bit a couple of studies that I think might be recent studies that I think might be interest to our audience. And finally, I will discuss about the holistic approach in the management and the role of the ERS and COVID CRC. So as we mentioned over the past hour, the respiratory tract is the preferred site of infection of the SARS-CoV-2. However, we have learned, listening previous speakers, that COVID-19 is a really complex systemic disease affecting different cardiovascular, renal, hematological, gastrointestinal, CNS systems. And we have also learned about a plethora of symptoms that might persist in patients surviving severe COVID-19. And this is the reason why we are now discussing here about the post-acute and the long COVID syndrome that have been proposed early after the pandemic. The point is that only recently we started looking at data at a 1-year follow-up. So the first message is that our knowledge in terms of prevalence, risk factors, management, and impact of outcomes of different signs and symptoms of the long COVID is evolving. So at the beginning, we were talking about 12 weeks, then we talk about 6 months, then 9 months, and now 12 months. This is a map concerning all the different publications and the distributions of studies targeting the long COVID worldwide. And the message here is that, as you can see, data about long COVID are coming from most of the big countries all over the world. And publications are targeting different human body systems. Not only the lung, but also the liver, the blood, the gastrointestinal tract, dermatological one. So we are having a good number of data in terms of distribution of evidence on signs and symptoms of long COVID across different human body systems. However, if you take a look at the number of studies that specifically target different organs, and this has been shown by this graph, you see that in the majority of the cases, lung diseases and thrombosis, stroke, and neurological diseases have been the topic of interest of the majority of studies on potential long-term complication after COVID-19. And so this is the reason why we should focus also to increase the number of evidence looking at complication for other very important human districts, like the psychological one, the central nervous systems, or even the liver disease. This is a pretty recent meta-analysis that is in a preprint format, so not already published by Lopez Leon and co-workers. Up to January 2021, more than 18,000 publications identified with the idea of looking at the complications of COVID-19, 15 studies evaluated, and 55 long-term effects estimated on more than 47,000 people enrolled in these studies. 9 studies were mainly from UK and Europe, 3 studies from the US, and 1 from Australia, China, Egypt, and Mexico. The key message of this latest research is that up to 80% of patients that have been infected with SARS-CoV-2 actually develop 1 or more long-term symptoms, including fatigue, headache, attention disorders, ear loss, dyspnea, and as we previously mentioned. So as soon as this systematic review meta-analysis will be reviewed and will be published, this is an incredibly important amount of information for us. However, if we take a look at the quality of the evidence according to the different sequelae and organ evaluated in people who survived from COVID-19, you see that, for example, for data on pulmonary fibrosis, which is a well-known complication of COVID-19, we only have a small observational studies, while we have a large amount of observational studies looking at the lung function and the impact of dyspnea. In terms of cardiac involvement, for example, the myocardial inflammation, which is something that we are really interested now because we are starting evaluating more in depth this complication, was mainly based on a case series, while the evaluation of the function of the heart in terms, for example, of diastolic dysfunction have been evaluated through multi-center observational studies. And in the majority of the other area, like the hematological one, the neurological one, the renal, or even the systemic evaluation, you see that we are always based on observational studies. So we don't have a very well done interventional studies that can change the trajectory of these complications. And in some cases, we still are based on data coming from case series or even case report. This is the second message I would like to share with you as a take-home message, which is just one of the examples of a patient-led research. This is an analysis of prolonged COVID-19 symptoms. It's a survey by a patient-led research team that came out at the beginning of May 2020. And the goal of this research was to capture the big picture of all the different experiences of patients suffering from COVID-19 with prolonged symptoms. So this was a survey, and the survey content and the survey analysis have been patient-centric. So the questions, the survey questions, and the symptoms were curated by patients themselves. Patients expert in research and in survey design, but the analysis was also conducted by the patient themselves, both qualitative and quantitative data analysis. And this kind of approach is really, really important, especially for COVID-19, because patients experiencing symptoms are in need of timely research and content relevant for them that might not be expressed by a physician-led research. So this is really important. In terms of common manifestation of COVID-19, we already discussed a little bit about that, and we know that it's a multisystemic disease involving the neurological, the psychiatric, the cardiovascular, the pulmonary, cutaneous, and a systemic kind of sign and symptoms. And if we want to summarize a little bit the post-acute COVID-19 complications by organ systems, we touched in the previous presentation most of the signs and symptoms, especially the pulmonary one in terms of dyspnea, in terms of hypoxia and decreased exercise capacity, in terms of hematological complications like thromboembolic events, in terms of palpitation or chest pain from a cardiovascular perspective. Very important, anxiety and depression, PTSD and sleep disturbances in up to 30-40% of the patients who are COVID-19 survivors. Renal dysfunction, endocrine dysfunction, some gut microbiome alteration. We have some good hypotheses about that. The air loss reported in 20% of COVID-19 survivors. And my presentation is mainly on adults, but we should also think about the impact on children and the so-called multi-system inflammatory syndrome, with some very important data that came out over the past few weeks. We also have an idea about predictors and risk factors for long COVID. These published in the International Journal of General Medicine a few days ago. It's a nice review also for patients that can put together not only the prevalence of complications, but also risk factors. So we identified older patients and different complications according to age. We can use abnormal lab results during the acute phase, but also after the acute phase as a predictor for long COVID complications. We know that patients with previous underlying disorders or comorbidities might be more affected than other patients for complications. And then we also have miscellaneous factors that should be always individualized on the single patients. So there are very nice research on trying to identify risk factors, where the implication for us as a physician is to individualize the right path to monitor and to follow up properly the patient, not only after the discharge from the hospital or not only after the acute event in the hospital, but also after 3, 6, 9, 12 months, or even, we don't know now, but 2 years, for example. I'm a pulmonologist working in Milan, Italy, so I would like to share with you a couple of slides about pulmonary complications. We discuss about risk factors, and we know that there are patients at highest risk for COVID-19 pneumonia complication. These are patients managed in the ICU or in the high dependence units, patients who are discharged on long-term oxygen therapy, patients who receive during the hospitalization or after the hospitalization positive pressure through continuous through CPAP or non-invasive ventilation. So we tend to follow more closely these patients during our follow-up. And from the beginning, these are data of 2020. We knew that there were CT features in COVID-19 affect that we were able to recognize not only during the acute phase, but also after hospital discharge. The importance of the CT scan have been put under the focus of us as a clinician and researcher at the beginning of the pandemic. We know that the CT scan can help us in identifying all the different aspects of the impact of pneumonia in terms of reticular pattern or ground glass opacity or consolidation during the acute phase and up to 4 weeks. And at the beginning of the pandemic, this is a perspective we published with Paolo Spagnolo in 2020. we started thinking about an evolution of the lung abnormalities into a pulmonary fibrosis for those who were hospitalized for acute respiratory failure and RDS due to COVID-19. With the percentages up to 20 and 40% of the patients. Also, the cardiopulmonary recovery after COVID-19 is very important. This is one of the latest studies published in 2021 in the European Respiratory Journal. I would like to show you this because this is a prospective multi-center observational studies that systematically evaluated the cardiopulmonary damage in patients who survived from COVID-19 at 2 time points, after 60 days and after 100 days. And through a questionnaire, but also clinical examination, laboratory testing, lung function analysis, CT scan, echocardiography. And what the authors found is that dyspnea was the most frequent symptoms, up to 36% of the patients, that there was an impaired lung function, especially in terms of reduced diffusing capacity, but also there was a cardiac impairment with a reduced left ventricular function, and sometimes also some signs of pulmonary hypertension, but these were present only in a minority of patients. And the good thing of this study was to a comparison between the signs and symptoms during the acute COVID-19 and during the follow-up phases. In terms of the evaluation of the CT scan, this study presented a very nice and elegant analysis through the evaluation of the CT severity scores done by radiologists, the evaluation of the pattern of pathological findings through the CT scan, and these and other important studies put the importance of lung function test and the CT scan at the top priorities in our follow-up of COVID-19 patients. This is another study looking at the lung function and demonstrating that the impairment of diffusion capacity is the most common abnormality in the lung function test, followed by a restrictive ventilatory defect, which is associated with the severity of the disease, according to a different disease severity, from mild illness to severe pneumonia. And pulmonary function test in general, not only a simple spirometry, but also diffusion capacity is now considered in the routine clinical follow-up for a specific category of patients who survived hospitalization because of COVID-19. Another important point of discussion is about long COVID complications in patients in people who have been managed at home, because the long-term complications after COVID-19 are common in hospitalized patients, but the spectrum of symptoms in milder cases is not very well known and needs further investigation. This is a study published in Nature Medicine recently, where the scientists conducted a long-term follow-up in a prospective cohort of up to 247 home-isolated patients and also 65 hospitalized patients in Norway. And they found that at 6 months, 61% of all patients had persistent symptoms, independently associated with the severity of the initial illness. And they found that up to 50% of home-isolated young adults between 16 and 30 years of age, they had symptoms at 6 months. Symptoms including loss of taste or smell, fatigue, dyspnea, impaired concentration, but also memory problems. So these are important data, important findings on young home-isolated adults with mild COVID-19 who are at risk for long-lasting dyspnea and also cognitive symptoms. The other big chapter is about the follow-up. So the majority of the data are on 3, 6, 9 months, but we are now having good data on 1 year follow-up. Like this one, this is a study published on clinical infection diseases recently, and patients were included at 5 months after the acute COVID-19, prospective design. Patient followed until 12 months after COVID-19 diagnosis. And what they found is that after 1 year, 23% of patients were completely free of symptoms. So only 23% of patients were completely free of symptoms. And the most frequent symptoms were exercise capacity, fatigue, dyspnea, concentration problems, problems finding words, sleep problems. And he also found that female seems to show a significantly more neurocognitive symptoms than male. So this is a big issue about 1 year follow-up and maybe 1 year and a half and 2 years. If you had the chance to look at this data, it's a nice study because it's also comparing the evolution of the symptoms during the acute COVID-19 phase, and then after 5 months, 9 months, and 12 months, looking at the differences. For example, take a look at the anxiety or the hair loss. You see that there is an increase or decrease of these signs and symptoms, which is significantly during the follow-up. And this is important for us because if we need to individualize the kind of testing to do in these patients, these are very important data. This slide is showing a podcast published in Nature, identifying the importance that COVID-19 has in terms of lasting disability or ill health. If you had the chance to listen this podcast, I would like to strongly recommend. And this is a podcast where the author discuss there are public health experts that are evaluating the impact on disability adjusted life years, the quality adjusted life years, and the new data that are coming out from the literature are showing that COVID can leave millions of people with lasting disability or ill health. And the speakers are asking to change the lens through this perspective, especially after all the data we have right now. The last 2 slides are about the holistic assessment that we as a physician are putting in place in the patients in the post-COVID-19 clinics. We tend to assess globally the patient, but also the lung problem, breathless, oxygen requirement, fatigue, anxiety. And the key message here is to try to build up a multidisciplinary COVID-19 clinic. There are plenty of these COVID-19 clinics that are based on an interaction of different healthcare providers, looking at the different body systems. So we have not only the pulmonologist, the hematologist, nephrologist, primary care, neuropsychiatric. So the key of success to monitor and try to reduce the burden of long COVID complication is into a multidisciplinary approach between the hospital and the community, working with a work between hospitalists, healthcare professionals, and GPs, and try to identify the specific area where we can do something for our patients during not only after hospitalization, but at least up to 1 year of follow-up. So I would like to conclude with four major questions that might be of interest for you. First of all, we know that long COVID exists, but actually how many people get long COVID and who is most at risk should be a little bit more elucidated, especially with a long-term follow-up, 1 year, 2 years. The underlying biology of some of the long COVID signs and symptoms is not completely clear and should be investigated, because here we might find some targets for therapeutical interventions that can change the trajectory of our patient history. Thirdly, what is the relationship between long COVID and other post-infective infection syndromes is interesting, because we know that most of the viral upper and lower respiratory tract infections might have a long-term effect. But now we are starting thinking of something different for COVID-19. So comparing with different situations, different viral infection might help us as physicians and researchers to better shape the management and the intervention for our patients. And finally, what can be done to help people with long COVID in a practical way, in a daily based way, is really important. And what I mean is to design randomized controlled trials of practical intervention that can change and can ameliorate the quality of life of people suffering of long COVID-19 consequences. This is one of the experiences that are worldwide, that are present worldwide for the long COVID area. This is the European Respiratory Society and COVID clinical research collaboration, which is a network of physicians, patients, researchers, but also pharma company and other stakeholders that want to work on consequences of COVID-19 infections, particularly in patients who have been hospitalized, with the aim of merging different national initiatives in Europe that are studying the long-term effects of COVID-19. And we want to build an integration platform that can allow us as a researcher to better interpret the data and to answer COVID-19 related research questions. There is a website, you can Google this, just put ERS and COVID CRC, and feel free to send me an email if you are interested in this and you want to cooperate. With this one, I would like to thank all the organizers, and I'm happy to take questions during the question and answer session. Thank you.
Thank you, Stefano. This was really interesting. I would like to announce the second speaker, Brice van Eeckhout from the Dragon Project, who is going to be announcing the Dragon Project research project later on.
Thank you very much. So first I want to thank the organizers and the European Lung Foundation for creating this panel discussion and for inviting me. So my name is Brice van Eeckhout. I'm the CEO of Communicaire, which is a startup working on patient support solutions for patients with chronic diseases. But I'm also here as a member, as a partner of the Dragon Project, which you might already have seen in some slides this morning, as the project is actually focused on increasing global response capacity to the COVID-19 crisis, but also to future pandemics. So in the Dragon Project, we are mostly involved in a subsection of it, which is about patient empowerment through decision support systems. and we're doing this in partnership with ELF, ERS, and BioSci Consulting. The main goals of the project, the subsection, are fourfold. So the first one is really to try to bring the perspective of patients inside of the project and its developments. And this has been done through the creation of a citizen and patient advisory group, but also by participating and getting patients involved in conferences such as this one. The second big pillar is about creating a wider stakeholder community. So there we are trying to gather the perspective also of clinicians, researchers, medtech developers, but also decision makers, for example. The third pillar, which is most the subject of today, is really about the development of multiple apps for the support of patients and citizens throughout the COVID-19 crisis. And the last one, of course, is the integration of what has been created inside of the Dragon project, which is mainly about decision support systems, so predictive models inside of the tools that we are developing so that it can also really benefit to patients in the end. So Dragon wasn't designed to work on long COVID, as the project was actually written in the early 2020. But we had to evolve and adapt since we want to develop solutions where we can add the most value, of course. And we can see that there is a shift of focus towards also long COVID, as this appeared to be a very relevant subject. It's touching a large fraction of the population. And we had insights on this, for example, through different testimonies of patients, such as the one of Ellen Parks, which was gathered by the European Lung Foundation. Of course, this is extremely relevant. However, it's still very difficult to develop solutions. First, because we have a large panel of symptoms, as we've seen also in the last talk. And because we are still at the early days of research done on long COVID. As the Dragon project is a European project, we wanted, in parallel of the development of our tools, to work on research which is built upon the insights that we already have, all the research that has already been done, and trying to do this on a pan-European level. And here in the research that we want to do, which is a study called COVINCI, we really want to focus on the evolution of symptoms of patients after COVID-19. The COVINCI study is a year-long study that includes patients which have had a positive test of COVID-19 in the last 6 months, that are majority of age and are able to use a smartphone. And basically what we ask participants to do is to regularly just answer questionnaires during a 1-year period. For this research, we've built a specific digital tool, as the whole research is done remotely, and I wanted to quickly present it to you. So here the patient, the participant goes to the platform, and before actually being a participant, it's about decision making. So do I want to be part of the research? So the first parts are about eligibility. So we check whether you're eligible for the trial. And we also present some information modules about the research. Then we have a short quiz, which makes sure that you understood the information correctly. And then we try to gather preferences to make sure that there is a match between the trial and the patient, that the patient is actually interested to participate. The second part of the app is more about the participation. So first, you're able to register very easily by signing an electronic informed consent. And then we can start working on the questionnaires themselves, which are in different format. And most of them are questionnaires which are completely validated and are already used in research, but really targeting long COVID symptoms. So where are we today? We are getting now the final ethics committee approval, and we still need to translate the tool in different languages, but we're really close to launching the study. And then the next step will be publishing results, of course, but also to use what we've gathered to develop a support solutions. So if you're already interested, if you have had COVID in the last 6 months, a positive test, and you're interested to participate, don't hesitate to already go to the link here or to scan the QR code. It doesn't commit you to anything. It just means that if you provide us your email address, we'll just send you the information as soon as the study is starting, so that you can decide whether or not you want to participate. So what is the point of this? Of course, the research part is also about making a tool to support patients. Before even working on long COVID, we are already finalizing a first prototype of a tool to support patients that are positive to COVID, but that can be monitored from home. I think the tool is interesting also in what we have discussed today about the need to get informed and to find the right information. So ELF has done tremendous work by consolidating a lot of questions that were asked by patients about COVID and long COVID, and to get them answered by clinicians. And this is the type of information that we will gather inside of the information part. Then, of course, we try to monitor patients through symptoms and parameters. This can be done manually, but we also have some devices which enable to automatically input the data inside of the app. And so you get a better communication with the clinicians from the hospital, which are able to actually monitor you and create video conferences. So it's all about getting a better communication and an efficient communication in a system, a healthcare system, which is currently under pressure. So this concludes my presentation. If you're interested again in this research project, don't hesitate here again to scan the QR code or go to the link. And of course, I'll be part of the Q&A. If you have any question, don't hesitate to do so. Thank you very much.
Thank you, Brice, and welcome back to all the speakers for the Q&A. I think this has been very interesting, and I see there's a lot of interesting questions. So now will there be questions for Brice van Eeckhout and then Stefano and Betty Rahman?
So one place I think we thought of starting is that people had asked about whether there could be a poll of how long people have had their symptoms for, and Claire was going to look at setting this up and asking the questions. Is that a good place to start?
Yep, I think we've got a poll ready to launch. Yeah. So you should see on your screens a poll about the duration of your long COVID symptoms. So it'd be fantastic if anyone who has got long COVID would answer that question. So how long have the symptoms lasted? Is that up to a month, up to 3 months, 6 months, up to a year, or already more than a year? So anyone who has long COVID or has had, please do answer that poll now. You should be able to see the results now. Danny, can you see them on the screen?
Yes, so I think people can see, so we've got a spread where the largest groups are the more than 1 year group at 30% and the up to 6 months group at 32%. So are we going to our main Q&A now for this session? Marianne, did you want to select some questions, or do you want me to?
I prefer that you select them. I'm starting actually to be a little bit tired.
Yeah, no, that's absolutely fine. So I thought that one of the questions that's come up recently in the chat that's of interest is that we've got many countries represented here and many different states of play in terms of long COVID clinics and clinical care. So I wondered if anybody had any views about kind of best practice or worst practice and how we're going about this and what's working. Does anybody on the panel want to suggest how they'd like it to work or how it's not working?
So if I may, Danny, I might start off with our experience in Oxford. So we have a very comprehensive team looking after long COVID patients, which comprises of respiratory physicians, intensive care doctors who are managing them, managing patients who are discharged from hospital, psychology support and physiotherapy. what is currently missing is the lack of other specialty involvement. And I suspect the problem right now is that the NHS is, overburdened by referrals from patients who have had long-standing diseases and who've had to essentially wait for some of their investigations and treatments. So the healthcare system, at least in the UK, particularly in Oxford, and I'm sure in other places as well, are really struggling to meet the demands of all patients, not just long COVID patients, but also patients from other. So, I mean, I think that there really has to be a restructuring of services. And I'm really looking forward to a multidisciplinary approach for every chronic disease rather than long COVID. And that way, you just have, a more comprehensive assessment for patients that come through. And you can refer them in the same clinic to, say, a cardiologist if you're worried, rather than wait for 2 or 3 months before the patient goes and sees a cardiologist or a respiratory physician.
If I may add something, Jenny, another important challenge is also the involvement of the general practitioners, at least in my reality, because our population of patients who have been hospitalized because of COVID-19 and have been discharged, we tend to organize a very nice follow-up in the hospital after 1 month, 3 months, and 6 months, and so on. But it's very difficult, at least in my own reality, is a good collaboration with the general practitioners. Maybe because we don't have good data from the literature of this kind of interaction between hospital and the community. And also what I think we are missing as hospitalists are those patients who have been treated with a mild moderate disease, treated in the house, maybe with oxygen therapy, that are out of our radar, and we cannot put in the follow-up multidisciplinary clinic in the hospital. And this is, I think, it's a interesting amount of patients that might need our help.
Anything else? Brice?
Yeah, maybe I can just add something from the discussions we'd had, because we had a focus group as well with clinicians to talk about long COVID, was about the fact that although there is a possibility to help patients in an outpatient fashion from home, there is still a lot of questions about being able to monitor whether the program that they are following is doing them good or not, and to assess whether they are able to follow programs and what level to do so. So there is a lot of questions still about what is the amount of training that patients need in the beginning at the hospital before they can be released and follow a program from home, which is still something we're trying to figure out.
Can I just, I know Marianne has also been selecting some questions. Can I just pick up on one other one that I saw that I think we haven't really covered yet, which was about kind of the health economics and societal implications of any long-term disability. That, we don't want to make this feel or sound any worse than it is, and we hope for the best, but we haven't fully embraced the health policy planning, the health economics, and the social science aspects of this. Who else do we need to be talking to, and what kind of conversations do we need to have? Who wants to start with this? Because it's really a scary one. It also has, employment law implications.
This is one of the most frequent questions that patients with long COVID are asking me in the clinic, especially because there is an impact from a neurological, psychological issue on work. So, and we don't have a clear law in Italy, at least in Italy, in my region, about that. And it's really tough for us to put together a letter because also the evidence is not so strong in terms of guidelines that we can really push strongly in the letter. You don't have to do something at work, just to be concrete. So unless the patient is really disabled and cannot go out from the house, or has clear symptoms during the work hours, then we don't know what to do actually as a physicians, because we are not supported by the local and national law.
To chip in my bit, I think this is one of the areas where we really need international agreements and international standards, because we can't all reinvent this wheel, and people in all different countries have the same requirements and the same rights, and we kind of need to start off in the same place to try and agree this.
I think the other problem, Danny, is that the whole concept of diagnosis of COVID and long COVID. So that opens another can of worms, because there are employers that says, did you have a positive PCR test, or did you have a positive antibody test? And then we know that the antibody levels don't last for long, and in some people. And so it is a really difficult question, and I think probably one that even the health minister is going to struggle to answer.
Yeah, so I think there's work for us all to do to try and push the agenda, nationally and internationally.
I totally agree. I think that I have worked with many different nations, and I think that we all tend to define things differently when it doesn't matter the subject. One country finds something more important than the other, always. So I think that is a very good approach, and I think that's a more collaboration between the countries. I think is extremely important in this.
And again, I think it's another area where we need such strong collaboration between the patient groups and the researchers and the clinicians, because it takes quite a lot of courage actually to stand up, to employer groups and stake your case. So I can see we have a lot about a range of different symptoms. Would anybody like to comment about? I can see questions coming up about long COVID in children that we haven't really discussed, which is, I think a very large group. And for example, in the UK, where I'm speaking from, a very hot topic at the moment, because we seem to be drifting towards a policy that it's okay to let COVID just rip through schools because children don't really matter and aren't affected. And it's become a very active debate in this country. So I'd be interested to hear opinions. I think we agree that notwithstanding the caveats about a higher risk in older people, I think we all agree that long COVID is a real thing across the life course in all ages that get infected by SARS-CoV-2.
So if you, I'm not a pediatrician, Danny, but I can comment a little bit. So to me, let me tell you something general. So since children appear to be less at risk of severe COVID-19 in comparison to adults, there might be the feeling that they could receive less attention from physicians and researchers because of this. However, we know that if we take a look at the literature, the MIS or PIMS, which is the syndrome I talked to you a few minutes ago, is present and it's a reality. Usually it appears 2-6 weeks after the infection. There is a plethora of symptoms with persistent fever, mainly GI syndrome, also conjunctivitis or even headaches, and usually they improve. So all these symptoms tend to disappear in few weeks. However, after in some children, it seems that after weeks or even months after the diagnosis of COVID-19, they also have a long COVID. Okay, it would be great to know if, from a pediatrician point of view, how is the comparison between the long COVID clinic we have in our adult patients and what they are doing in children. I'm not doing that practically every day, but I collaborate in some sense with our pediatricians. And the way to think is pretty much the same in terms of the lung. So pulmonary function test, lung ultrasounds, more than CT scan, in order to evaluate the pulmonary involvement. Then they have a big expertise in inflammation, in systemic inflammation, and in all the long-term inflammatory complication that children might have. We don't have as a pulmonologist of the adults. Still less evidence, and in my opinion, at the beginning, a little bit underestimated kind of situation.
Thank you. Yeah. So I think we're going to another break in 1 minute. There's a question in the chat that I've been kind of looking at for a little while now, puzzling over, which is there a difference in long COVID profile according to which variant you were infected with? So in my lab, we're always racing to develop the story on each new variant as it comes along. We don't yet have a story about long COVID with different variants, and I don't think anybody else does. But I'd love to know if anybody on this call has any evidence, anecdotal evidence. It was different after Alpha, or it was different after Delta, or anything. Really important to know. I certainly don't know. Let's leave it out there in case anybody can tell us the answer. So I think we're going to have another break.